Is an instruction course in viral endothelitis, and myself Dr. Prafulla Maharana, and I'm going to I'm the chief instructor for this, and the first speaker Dr. Ritu Nagpal, I think she is going to cover the overview of endothelitis. However, due to some reasons she couldn't join us, so Dr. Sumit Lahane, he's going to cover both of that. So why we planned this IC? Because lately we are getting a lot of cases of viral endothelitis, and most of them are misdiagnosed either as chronic angle closure cases or some case of toxic endothelitis, or in fact some cases of Fuchs endothelial dystrophy. So I thought let's have an IC on this, so that at least we can convey to you how important is to diagnose a case of endothelitis, because if you start steroid timely, that makes a huge difference in contrast to other forms like Fuchs, where your treatment is only endothelial transplant. So I would like to invite Dr. Sumit for his talk on diagnosis of viral endothelitis. And meanwhile, Sumit, you can also discuss on overall types and patterns of viral endothelitis to cover up for the first talk. Thank you, Sumit.
Very good morning, everyone, and thank you, Praful sir and AIOC for accepting this IC and giving me opportunity to talk in front of all of you. So, as I said, we'll be talking about viral endothelitis. Viral endothelitis, in fact, endothelitis is a great mimicker, and many diseases can present as endothelitis. Let it be bacterial, let it be toxic, or the viral. Majorly, we'll be talking about the viral etiology in this IC here. So when you see this kind of a cases all together, they all look same, that what is happening to it, and when you have three more added to the picture, it becomes more confusing than helpful. So how do we deal with that? So we'll try and make it as simplified as possible. So in general, whenever you want to classify endothelitis, we classify into the four different stages, four different types. The very first is the linear, the another is sectoral, disc shape, and the diffuse. The name itself indicates that this is all because of the shape with which they are presenting. Either they are linear lesions, or they are sectoral, or they are so diffuse that they are not keeping any limitation of any boundary. So just to show you pictures here. Now this linear is what exactly? Is it the Descemet fold that you are seeing? So linear here is the keratic precipitates that you are seeing. The lesions on the endothelium, they are in the linear manner. So we are classifying this as a linear endothelitis. Similarly, sectoral one, they are in the one part of your cornea, either superior, inferior, central, wherever. This is again classical of HSV though, but it can be with the toxic endothelitis. This picture could be there. It's a deciform keratitis which involves part of the posterior stroma and the endothelium as well. And the last is diffuse, which is more dangerous, where the entire endothelium is affected and you don't have any borders as such of your endothelial lesions. Now why this is all of concern? Simply because you see a corneal infiltrate, you are unable to diagnose. You can simply go and scrape it off, send it to your microbiologist. Within 24 hours, you have a diagnosis. With the endothelitis, you cannot do something like that because the lesion is on the posterior side of the cornea, not on the anterior. So we'll be talking about the three main types and the three main etiologies of the endothelitis. The very first is the CME endothelitis. Now CME endothelitis, why it is important? Because as per our normal routine teaching, we consider CME is a disease of the immunocompromised. But the exception to that rule is the CME endothelitis, which can happen even in an immunocompetent individual. Now, the largest study published was from the Japanese population, and they reported 109 cases, and they list out the certain factors which are high risk factors for your CME. Why you should know that? Because you are seeing a case where you are suspecting an endothelitis. If the patient has undergone corneal transplantation, putting steroids for long term, and locally immunosuppressed, not generally, locally immunosuppressed, he could be suffering from the CME endothelitis. Now you see these 9 pictures, all of them look confusing to you, but very important here, you need to see the keratic precipitates and how the patient will present you. The very classical description of your CME endothelitis keratic precipitates is they are coin-shaped lesion. C4C, they are coin-shaped lesion Of course, there will be corneal edema because endothelium is in the shock post endothelitis and the pump function is not going on as it should. There is mild anterior chamber reaction. You need to know that endothelitis will always be accompanied with your uveitis. And of course, there is ocular hypertension, again a very, very important factor. Now, why it is so, we'll come to that later. How do you diagnose? Suppose clinically you are seeing it for the first time, it becomes difficult to comprehend all this picture and make it a clinical diagnosis of it. So you have some modalities available like a polymerase chain reaction. It's a test which you can do with your aqueous humor, or you can do a ELISA test for the CME antibodies. In vivo confocal microscopy in anterior segment OCT. So confocal microscopy is very sparsely available, but OCT I think most of the practices have. So OCT will show you, is it linear, is it coin shaped, how big it is, how much area it is involving. So you are seeing a case of keratic precipitates, uveitis, you are suspecting endothelitis. AIOS-OCT becomes a must modality to document that what is happening to your endothelium at the endothelial level. And this is just for you all to remember. The confocal microscopy gives a very classical aula morphology of the cells of the endothelial cells in cases of CME endothelitis. So all these are very important features. Now, as I said, the risk factor is a corneal transplantation done, and along with the corneal transplantation done, your patient is on topical steroid for the long term. Now this patient is coming to you with some kind of a reaction which is shown here with the arrow. A very first thing that will come to your mind, this is a graft and this may be a rejection, which all of us need to be worried about. And since the rejection needs a different treatment than a CME endothelitis, but at the back of your mind you should have idea that this small coin shaped keratic precipitates could be even a CME endothelitis and not the rejection. So of course you need to do AIOS-OCT, if possible confocal. If these lesions are not responding to your topical steroids, then your aqueous tap and the PCR becomes must to diagnose that you are not looking at CME endothelitis and rejection. Another feature you need to look is intraocular pressure. Like any endothelitis, like I said, it will come along with the uveitis plus trabeculitis and it will lead to raised intraocular pressure. So again you want to differentiate between are you looking at the rejection or are you looking at endothelitis. Please do check intraocular pressure. CME endothelitis, HSV endothelitis will present with the higher intraocular pressure than other reactions which mimic that. Moving on to another one, HSV endothelitis. Now this is a very classical virus which behaves very differently in the epithelium, in the stroma and in the endothelium. And in the endothelium it can cause all types of endothelitis. It can cause diffuse, it can cause deciform, or it can cause even linear. Again a classical appearance of keratic precipitates. AIOS-OCT is must in such cases. Again diagnostic modality to be very, very sure, the viral culture, PCR or the ELISA are very important diagnostic modalities. Compared to all, this is a very common disease HSV which present with the endothelitis along with uveitis along with the raised intraocular pressure. So you need to add systemic antivirals along with the steroids to treat this. Coming to the last, VZV endothelitis. In zoster endothelitis, of course, it will be a little larger coarse capes compared to the HSV, and this is a very classical lesion. So if you see a patient along with sectoral iris atrophy or old sectoral iris atrophy and patient coming to you with the repeated complaint that I am having redness pain, they may not be recurrent attacks of anything else other than the VZV virus. Again you need to do a AIOS-OCT because it is a documentation tool, and the very important, the diagnostic modality is PCR. So the point to be taken here is that when you are looking at the endothelitis, it could be CME, HSV or HZV. The very best that you can do for such cases that when you do aqueous tap, send for all the 3 PCRs. Many of the labs do all these 3 together, but if you write it specifically, you may miss the diagnosis because sometimes they do mimic each other as well. So when you look at all these 3 and try to think about it again, just give it a time, see them again and again, you can easily diagnose clinically itself that you are looking at the endothelitis. It could be CMV, HSV, VZV, and that diagnosis very well can be made on the slit lamp examination itself. So looking at this lesion and thinking about the differential diagnosis of viral endothelitis is very important. So it can be associated with the other differential diagnosis like toxic, bacterial, otherwise as well. PCR is the best diagnostic modality that all of us have. Recurrence is risk factor in all three cases which you need to counsel patient for. Early diagnosis in the treatment is necessary in such cases because simply till you are not treating the endothelitis adequately, the endothelial cells are dying out there and you may get the patient with complete endothelial decompensation post endothelitis. So this is something as an emergency we need to treat as early as possible when you see the endothelial lesions. Thank you all for the patient listening.
Thank you, Dr. Sumit, and that was really a wonderful talk. You covered the initial part also. So since we want this to be more interactive, any suggestion, any question from the audience, or any real life practical scenario that you have encountered for such cases?
So to describe, since you asked my own case here, so I had a patient of full thickness graft, and it was a second time done graft, and first time it was rejected. So and patient presented on the 6th week with redness, congestion, pain, everything, photophobia. Staining was negative, but I could see the AC cell reaction. KPs were very linearly arranged, and I could not think about a diagnosis of any endothelitis. I treated patient with the steroid for 3 to 4 days because for me, the patient of the rejection is coming with the rejection than anything else. It took me 4th, 5th day to see patient again and realize that he is not responding at all, and I had to do a AC tap. On 3rd, 7th day, the diagnosis came that what I was dealing with was basically HSV because patient was on steroids even for the primary rejection and for the second graft. So even as a cornea surgeons, we do miss. So it is bound that if you are unable to get the treatment or get the outcome with the only steroids, then the antivirals are missing in the picture and you must do something more for the patient.
I think we've all encountered such scenarios, and most commonly when we talk about endothelitis and PBK, if it's a pseudophakic with an endothelitis, we are bound to get confused that we are dealing with the PBK. It is very difficult to get those very localized KPs when we talk about, and if you've done a DSEC or a DMEC in those cases, even after that you can always have a recurrence. I'll show in one of my cases that we didn't know. We treated it like a PBK, did a DMEC for PBK, and then after that had a geographic also. So it's sometimes after your surgery you realize, oh, initially also we were dealing with a viral. So masquerades in viral is very common. For endothelitis, yes, PBK becomes that. So most of the time, I think if it's a phakic patient, it's very clear. Most of us do give a trial of steroids before we think that, if you think that it's not exactly Fuchs, you think of viral endothelitis as one of the very common causes. But sometimes in pseudophakic, it is possible that you've missed. So it's not something which you cannot miss.
My first question is, as you have told, so how does the treatment of HSV and graft failure differs? Number one. Number two, did you encounter a case of endothelitis due to Calotropis diabetica? Because in our sector, we are regularly getting, and they will not give the history of that fall. So our first question is, have you plugged that flower or not? Because treatment is different. And number three, in case of HSV endothelitis where this separate, they are steroid dependent. The moment they stop steroid, again it will recur. So what is your take?
So a lot of questions were there. First part was Sumit.
Yeah. So first was how do the treatment of rejection and the viral will differ. So it's basically when you have a viral endothelial lesion, steroids is a must that you are going to give. The systemic antiviral is missing, and in cases you need to start with the oral acyclovir, ganciclovir, whichever viral you are treating for the higher dose, and then accordingly treat the patient. The topical will not help here, the systemic will help. The systemic is must. So the second question was Calotropis.
So calotropis, so those who have encountered that, they would know how to diagnose it. Typically toxic endothelitis, its presence at the central corneal edema. You won't get any linear or diffuse fold that you classically seen in endothelitis, but the folds are like whenever there is corneal edema, there will be descendant folds. So those folds will be like that, and of course the history. At times the clinical features are so overlapping, it must be some Shivratri preceding, or that patient must be a Shiv Bhakt. That is that. Yes, limbus, everything will be fine, only local corneal edema will be there. So that's a very important point. That's a very important point. You give you steroid resolve, but there is an article in Cornea. If you understand toxic endothelitis, some low grade inflammation do continue. Even if the immediately within 1 week everything resolves, but some low grade inflammation at the level of endothelium continue. So few physicians, they propagate a gradual taper. If everything is resolved, don't stop the steroid right there. Taper it over a period of 6 to 8 weeks for all cases of toxic endothelitis. Any?
I also practice the same thing.
So third question was?
Third is that steroid. I think you answered already.
Steroid depend, a lot of PGs are here. So there is a classic line in Krasmer's book which suggests a lot of patients of recurrence are primarily because you stop the steroid prematurely. Yeah. Steroid has to be titrated depending on the severity. If the endothelitis is severe or endothelial edema is severe, you have to taper it over a period of 2 to 3 months, and tapering should start based on the clinical response. It shouldn't be like weekly once you are tapering, irrespective of the severity. So the starting dose as well as the tapering dose should based on your clinical response, not the diagnosis.
And sometimes even if you...
Ma'am is going to cover that. Recurrence is, there is a...
No, I will be covering that, but when we are asking the question on that, whenever we are giving steroids, especially for endothelitis, where we know it's an immune component which is involved, and CD4 cells are the major cells which will again propagate and bring it back. So there, it has to be a very, very slow taper. So sometimes up to 3 months or 4 months, the steroids will continue, maybe once a day, and sometimes even after that you have to do that, because if you stop it, then the recurrence normally which comes back may also come back as a stromal necrotizing, which is something which you really do not want in those cases.
I think we are done, ma'am. Okay. So next will be our speaker, Dr. Manisha Acharya, ma'am. And I have heard about...
Can somebody help here?
The study that she has done in this pathogenesis and management. That's why I invited her. You should share this with us also. And recurrence is the major problem. I have a lady, civil service aspirant. She gets 2-3 recurrences every year, and each time it takes almost 4 to 6 weeks for her to recover, and that's a major problem with her. And we are giving acyclovir, we are tapering steroids slowly, but still they get recurrence. So how that happens, what that happens, and how to tackle that, Dr. Manisha Acharya is going to cover that.
Yeah. So till ma'am is setting her mic, how many of you have seen custard apple keratitis? Custard apple. So many of the people in village area, they apply custard apple seeds extract to their hair for certain hair treatment. Even that can present, but that is majorly a stromal involvement, stromal and epithelium, and not the endothelial. The treatment here differs completely, because there we generally avoid steroid to a certain extent as much as possible. So the asking history, ma'am, with the calotropis and this custard apple is also important.
And also when you're talking about it, endothelitis, you've already spoken, intraocular pressures here will not be 25, 26, they will be around 40. Yeah. So that endothelitis along with trabeculitis is very, 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 it is a combined modality which comes. So thank you, Dr. Prafulla, for giving me this opportunity and making me part of this instruction course. I also thank APO AIOS for this opportunity. So recurrency is something which is very close to my heart, and because I deal with infections in our hospital in the department, I'm just going to share a story of this 45-year-old gentleman who had been having recurrent episodes since 20 years. And when he came to us, he was on low and on oral as well as topical antivirals, and also low dose steroids were also on. along with artificial tears. So that was like immediately full-blown stromal necrotizing keratitis is something you're seeing. Within 2 weeks, the lesion started responding on an infective level, but immunologically level, it started to thin out. So we went in for AMG and tarsorrhaphy, and with the treatment and palliative treatment, it started to respond. And within 3 months, we were like, okay, the cornea has healed and scarring has started. Patient was started again on prophylactic antivirals so that to counter recurrence, because he was already having recurrent attacks, not using. A compliant patient, he was there. But how much compliance is what you explain to the patient. They do at times, after we had some problem and they immediately stopped it. And once stopping 6 months, he was very compliant. After that, he stopped. And within a week, he came back to me with recurrence. And after prodding, I was taking medications, but I just stopped for 6 days. And then he came with recurrence. As you can see, superiorly, there was an epithelial defect. And then after 10 months, he was again obviously started with full dose antivirals, responded, and then prophylactic antivirals continued. So he's a young gentleman who's been, at times when he comes with the first picture, you feel that you really, it's very difficult to treat and complete loss of vision. But with proper treatment and understanding of the disease, you can manage these patients better now. Before going further and understand the virus. We're dealing mostly, the viral is mainly HSV is the predominant which we know of. It is actually a DNA virus, and that it is a linear DNA which is there with icosahedral capsule which is there, and the glycoproteins which are over there. There are more than 150,000 base pairs on that, and in that linear DNA there are LAT, that is the latency associated transcripts, which are non-coding RNAs. I know it's a little difficult to go back on that, but I would just request you all to just remember the LAT, because they are responsible for preventing the viral replication and suppress the viral lytic cycle. So there is active replication of the virus is something which is stopped by LAT. So I like that virus. I like that non-coding part, because it's going to stop the lysis of the cell, and virus will not propagate. So when we talk of HSV virus, it is basically first going to, most of the time goes to epithelia and the sensory neurons, and then there is one part we all know is a latent infection. And whenever there is a stress or a stimulator factor, again the reactivation of the virus starts. And it is that which will lead to the recurrence of the virus. And HSV can continue replicating in cells, or it will go enter latency by traveling to a ganglion, which most of us know most commonly is the trigeminal ganglion. So with this we know that HSV can exist for a lifetime in the infected host. And as we grow older, the infection chances increases, and there are studies which say that more than 80% of people will harbor HSV in some way or the other. If you go for the classification of HSV keratitis, now the recent classification is primarily on the disease location. It is classified as epithelial, stromal without ulceration, which was initially called as immune or non-necrotizing, and stromal with ulceration, which we used to call as stromal necrotizing, and the endothelial, which initially was called as disciform. And this is now most of us are following, as it is more relevant. The management becomes easier if we go by that. But why are we all here in this room with an IC on a specific part of viral? Because this is a puzzle. HSV keratitis is a puzzle. And mainly because of 3 problems. They have varied clinical presentation, limited treatment options. When I graduated, there was acyclovir and ganciclovir. Today also we have acyclovir and ganciclovir. So nothing has evolved much when it comes to that. Unpredictable recurrences. Whenever we feel we've dealt with it, again comes a recurrence. Just before going further, the host immune response in HSV keratitis is also important. And in our body, both innate as well as adaptive immune response is there to combat HSV when it enters into the body. Because the lytic replication is going to take place when the virus will come in contact with the cell, mainly of the epithelium if it is coming from the outside, and it will lead to a raised lesion, and later on it will lead to breakdown. So both the immunity becomes important in that. And there are certain immune cells which become important in pathogenesis. I will not go into the detail of that, but we know that one is the stage 1, which is the rapid response, and the early response and late response. Early is mainly neutrophils, we know that, and in late you will have dendritic, macrophages, natural killer cells, and subset of T cells. The T cells are mainly responsible for the endothelitis or more of the immune component, while the others are for the overall HSV, where it will also go into the epithelium or in the stroma. Now, I've been asked to speak about pathogenesis, so I had to take you all to that level of understanding how it's going to be. So when we go for epithelial keratitis, the pathogenesis is mainly it's coming on the epithelium, the lytic replication where the virus comes in contact with the surface of the cell through glycoproteins and use the host machinery for its replication starts there. First, it will just lead to punctate epithelial keratopathy, then a raised lesion. And most of the time, if our immunity in the form of interferons and HIV specific IgG, IgA is good, it will not go further and we will not even manifest what is happening. So we will not feel that we've had the disease, and maybe we had some subclinical problem. And sometimes when you just have SPKs and you just give tear substitute, it resolves. That is why when acyclovir was not there, the epithelial dendrite was considered as a I would just say a self-limiting disease like a conjunctivitis, because the host immunity used to come up and it used to take care of that. But these dendrites may also coalesce to form a geographic if your immunity is not good, the immunity of the person and that factor is not taken into account. The stromal keratitis, when it occurs and it goes more deep, there will be an early phase as well as a late phase. So again, a triad of immunopathological problem which is happening, because early phase will have more of neutrophils, and in the late phase it will come up again. Here it will not cause lysis, but it will lead to angiogenic. That is why most of the viral keratitis, if it is stromal or below, it usually leads to neovascularization. The scar with neovascularization we say is because of viral. That's one of the differentiating when we go for scars. And that's how it presents over here. And if the invasion or the evasion, whatever is powerful, it will go to that level of that. When we talk of endothelitis pathogenesis, as I have just said, that it is more immunological, and there are recently now only animal studies which actually have proven some part. It's usually said that it's a combination of the CD4 cells and also the inflammatory milieu which is created by the HSV corneal infections. It is a non-specific binder. But mainly the T cells are the ones which get excited, and they act on the endothelium per se, leading to damage of that cell or lysis of that cell and leading to edema because that is not functioning much. And later the surroundings one will go over there. And once you suppress it with steroids or other immunomodulators, it is going to, the damaged cell may recover or it may die forever. The second problem which I was just saying was unpredictable recurrences. So this was one of the cases came to us so bad. Every time it was perforated, we didn't have much of an option not responding to medical therapy. At this phase, we do not. We had no option but to go in for therapeutic keratoplasty and under strong full antiviral cover, like a 5 times the oral as well as topical. But again, even with that high dose, it did develop recurrence. I would not even call it recurrence here. I would just say it was more of a residual infection which was still there, because however large a graft you take, it may have disseminated beyond that. This was another case what I was just talking about, post-operative corneal edema which was present, and more so at one area, but a diffuse corneal edema, thought of as PBK, operated for DMEC, and later on developed on the epithelium the geographic sort of ulcer, because obviously the patient was on steroids but not on any oral antiviral here, because we did not. And finally, when kept on that, it did resolve. So why does recurrence actually happen, and what makes this HSV1 latent? Again, we had spoken about LAT, it plays a crucial role in the latency because it has two factors. It represses the transcription which halts the lytic cycle, so it will make it dormant. It will not allow the virus to replicate more. And also sometimes whenever there is a reactivation trigger, it is going to cause a problem. Now why is it important for us is, as a clinician, we are happy if the virus remains latent. So I'm happy if it is latent and not causing any immediate problem to the patient, because we know it's harboring there. So can we find out how it is? So neuronal latency is on the ganglion, But is there a non-neuronal latency also there? There have been studies which show that viral latency in retina and cornea is there. But it's still an area of controversy, and a lot of studies are going on to prove it. But why do some develop and some do not develop? We just know that there are evasion strategies which are there, which is because of the immunity. And there is again, if you look at the pathogenesis, there is lysis happening, but if the immune response in the HSV evasion strategies having those interferon gammas there, that overtakes, the infection will finally halt, or it will not allow it to occur. But there are certain key cytokines which are there, and some which will halt the viral replication and which will cause inflammation and neovascularization. But a balance is needed so that there is minimal scarring which happens. A lot on the molecular level. I'm just going on this one-eyed patient who had again a recurrent keratitis, presented with perforation. We went in with the cyanoacrylate glue, responded, stopped ACV after some time, and then again had a recurrence there. So how to treat them? We are clinicians here. Finally, we need to treat recurrence. A very good study on form of head study has been done, and a lot of credit to whatever we do in viral goes to this study, which was a randomized double mask study in 1989. And I would just go to that level where because I'm dealing with recurrence. So a recurrence, when they did the second part in the head study, was the prevention trial where acyclovir 400 milligram BD was done, and it reduced the recurrence to 41% and 50% decrease in more severe keratitis. We all still follow that. But if you look at it, there were certain limitations of this study. If you go into the depth, you realize the dosage which came was from dermatology. It did not come from any human trial, that why 400 milligrams should be adequate for me or for somebody who's 40 kg and somebody who's 60 kg have different immune profiles. So we still don't know what to do. And there were others, but this was what is pertinent to us. So this is a very recent 2025 still in print, and it gives us the clinical strategies for prevention. There again, we have limited drugs in form of nucleoside analogues, acyclovir, ganciclovir there, where they actually inhibit viral DNA polymerase. And resistance is also now which is noted, and I will not go into the molecular level, but yes, oral antivirals do well. So to summarize what was there, the tablet, I'm talking of acyclovir more on our context, 400 milligram BD is something we normally do. And again, what we know that less than 50%, it will not allow the recurrence to occur, but still it can recur even on that. So sometimes I feel it's not because the coverage was not, maybe the dose for that individual was inadequate. So in the next time, you have to increase the dose. Periodic RFTs are needed, but it's a very safe drug, and ideally it's a lifetime prophylaxis or for recurrence which has to be taken. And when I was going through this article, I realized even they agree to what we all discussed, that optimal recurrence-free interval before corneal transplant is not definitively established. A minimum of 6 months is something we all agree. 1 year is something we all follow most of the time. So if I go again with this patient, where the patient presented with infiltration and melting, resolved with antiviral treatment, but again stopped, we went in for keratoplasty after a year. It again had a recurrence for that. So recurrence are there. So can a biomarker predict recurrence? We have studied so much about immunology, but when should we know this patient will recur and this may not? So there are some cytokines which are there, which may help us in predicting can there be recurrence. Just 1 minute of that. This was one of the patients who presented to us, was on, we started on oral antivirals as well as topical with steroids, and we started doing gene expression level of a particular biomarker, which was IL-6 here, and we found that at the very presentation it was high. When responded, it reduced, but again came with a recurrence. And if you look at the third visit which is there, it again showed an elevation, which means that somewhere it's not, it's increasing, but with the recurrence. It's not there with when the patient was responding. The patient again, when they stopped and had a recurrence, and 2 months later, when the patient was on oral antivirals, the levels of the biomarker of the IL-6 again came down. So maybe this may be one of the markers which can, levels of these markers, which can tell us that, okay, now it has come to quiescence, can we go in for that? But it is not something which is immediately there. There is need to understand HSV keratitis better and at molecular level. We at our hospital were treating it in clinics till 2022. Now I am moving from with clinics to the molecular lab with scientists and trying to come up with some biomarker identification. That has been my pain point. How I should be able to differentiate that this may progress and this doesn't need. Because starting long-term therapy in any patient in our country is not a very easy job. Tell them you use it for lifetime, it's not easy for them to afford. It is a 30 rupees therapy for a day for our patient. And you go even in the Pradhan Mantri Yojana, if you send them to the least cost effective, if you want to go in for the cost effective ones. So translational research is something we need to do now, and these are the ongoing projects which we are working on HSV keratitis in our hospital, where we are studying by various markers and how we strategize later on that how we are going to treat them, common modalities of epigenetics and also mesenchymal stem cells. These are the publications which we've had so far, and the awards and the allocates for our various scientists and students in various conferences. Thank you so much for your patience here.
Thank you so much, ma'am. Definitely we need a lot of understanding. Next, Dr. Sujata Das from LB Prasad Bhubaneswar is going to speak about if you have multiple recurrences, definitely the patient is going to develop corneal scar. So how to deal? Most commonly we do penetrating keratoplasty. So how to optimize the outcome in such cases? Thank you, ma'am.
Good afternoon. Thanks, Praful, for including me. So I'll be speaking on how to optimize outcome. It cannot be zero like Manisha mentioned. So we know that initially it was thought that HSV keratitis scar is in the developed country. I think it is not true. We see a lot of corneal scar due to HSV keratitis. The survival of graft from the corneal scar is due to HSV keratitis is 14% to 61%. And in all surgery, the herpetic keratitis recurs, but in keratoplasty, it is the highest one. And it is a high risk graft. We know all of those who do graft, we know excellent prognosis. This is one of the highest high risk graft failure, and recurrence is the leading cause of the graft failure. So I'll discuss few cases and indication and pre-operative planning and post-operative concern. So this is a patient who is 43 years and he complained of blurring of vision, left eye 1.5 years and history of recurrent irritation for last 6 months. This vision presentation was 20/30/320. You can see the vascularization. So anytime I see a corneal scar, if I have not seen, I ask for the recurrent redness and all. If not proven, otherwise I'll think this is HSV. And we know DALK has lesser recurrence chance compared to PK. So 3 months later, patient underwent DALK, and post-op vision was 20/80, and he has interface Hedge. So he was lost to follow-up, came after 3.5 years, and vision was 21/50. So he underwent PK, HSB, PK with cataract IOL. And anytime I do, I prefer to send. If I have not proven, I'll send for HSB PCR. I always feel if somebody has a dendrite, it is already proven. He was doing well till 9 months, 2030. And at 1 year, he comes with a dendrite and a endogeographic ulcer at the junction. So there is no time limit when we can have this. It is earliest is 1 year, within 1 year maximum thing, but it can recur after years also. So although the PCR was negative, so many time if it is a conventional PCR, it may come negative. Real time PCR is the ideal one, but many don't have. So he was treated for antiviral. So with time, it responded to treatment. Similarly, another patient, pain, redness, watering, he has recurrent episode. He presented with HSB necrotizing keratitis. So we treated him for necrotizing keratitis. It healed. So again, he presented with another infection. Most of the time they get superadded infection. So he was treated for that, including azaglobir. So scraping was GPC. Most commonly you get superadded infection with bacteria. You may get fungal, that is difficult to treat because you can't give steroid. So he underwent TAVCL and scar, then underwent again HSV PCR is negative. So my point is, even if HSV PCR, if you have a clinical suspicion, you can go always give oral anticyclovir cover. So again, loss to follow-up came after few edema. So this time the recurrence is not as a dendrite, but because it was HSB PCR negative or somehow it was not given, he was started as a rejection without an so you can see the corneal KP is a decrease, but you can see big trend, right, because systemic acyclovir was not there. I think it was a contraindication because he had renal disease, then topical acyclovir, and KP is always, you can see the graft host, it is restricted to only to graft. So post keratoplasty herpetic keratitis is maybe recurrent from HSB. Most of the time it is reactivation and new through donor cornea, but you can't do donor cornea screening because it's so less. So I'll just speak not reactivation. I'll just speak if it is a known HSB scar, how do you plan? This is also important to optimize outcome. You may not do. If you think the patient may not come for follow-up, it's better not to do. Especially if it's an old one, other eye is doing normal. So you need to check whether first history of herpes clinically or microbiologically proven, corneal sensation, and last reactivation, like Manisha told towards end, ideal for 1 year. And compliance is, any transplant I ask for compliance, but because here the drug also is important, so you need to compliance for long-term follow-up. Because you are doing on a neurotropic keratitis, they may need lot of lubricants later, a bandage contact lens. Some people do tarsorrhapy during the surgery also. If you know the develop epithelial defect, no, not a bad idea to do tarsorrhapy. And another issue challenges in HSB keratitis is vascularization. Topical corticosteroid need to be given to decrease the vascularization. You may give anti-VEGF or combination of all those. So post-operative, you expect persistent epithelial defect. Some people may do AMG also along with keratoplasty. So the challenge is, one is reactivation of HSB and graft rejection due to reactivation or vascularization. So as I mentioned, highest risk is among all ocular surgery. Cataract also may lead to reactivation, but PK is a highest risk, and it because 360-degree nerve is disrupted and you use long steroid. So mostly occur at the graft host junction with dendritic or map-like lesion or stromal infiltration. You can see out of all transplant surgery in PK it is highest and DALK it is least. And highest rate of epithelial recurrence and rejection happens in first year after transplantation. But whatever I see, I've seen after 6-7 years also. So can happen in early or late post-operative period. Early phase due to, because you do surgical trauma definition and all. So early phase it's due to surgical trauma which precipitate viral shedding in the tear film. In late phase, resonating corneal nerve act as a conduit for the passage of infectious virus from site of ganglion latency to cornea. So this study already shown by Manisha, where prophylactic acyclovir has less chance of recurrence, at least given for 1 year. So there are several studies which says about oral role of prophylactic oral acyclovir for herpes. There is no consensus, however. Some people give for 6 months, some people give for lifelong, some people give for 1 year. But the question is the cost here. So this study says the effect of routine use of prophylactic acyclovir after PK for recurrence, rejection and graft failure, and they concluded 80% of patients who received prophylactic acyclovir post-surgery lead to fewer rejection and improved. It is not zero, lead to fewer rejection and improved graft survival. Again, the question is dose, how much you give. It is 800. If you give 400 milligram once daily, it is not going to work. So this is for the duration and the doses. So HSB keratitis, if you give a higher dose of oral acyclovir, they have a fewer recurrence compared to lower doses. So lower doses is 1000 milligram per day. So basically oral acyclovir 800 milligram 3 times a day initially, in later period 400 milligram, which is routine practice, 400 milligram twice daily for at least 1 year, reduces the recurrence rate of HSB keratitis after penetrating keratoplasty. What about the success rate? DALK has, this is a Cochrane review, DALK demonstrated few complications compared to PK, and higher graft survival rates were associated with higher acyclovir doses above 800 milligram per day, along with topical steroid and antibiotic. So in the Cochrane review, it has concluded that post-operative visual acuity is same both in PK as well as DALK. However, the less severe cases of HSB recurrence in DALK and few complication and better graft survival. So in case the DALK is possible, we should do DALK in comparison to PK, and high dose of acyclovir contribute to improved post-operative outcome. So again, this Cochrane review has a comparison between PK and DALK. So this, I forgot to tell you, either we do in a quiescent or necrotic. Most of the time we try to do in quiescent phase, but it is a big population we do along with it is a tectonic purpose. So the first one is the only PK. You can see the if topical only the significant difference in their graft recurrence rate is 44% and rejection is 46%. This is comparison between the quiescent and the desmatocyl. So in quiescent, the 29% rejection and 10% graft failure. But if you do in a active stage, 31% rejection and 23% graft failure. So this is 5-year graft survival. There are studies of 1-year graft survival, 5-year graft survival. So this also says if you give first 6-month prophylaxis, the 5-year survival is better. So, but however, all the studies had a dilemma whether long-term prophylactic regimen lead to resistance. But acyclovir resistance is not so common like antibiotic resistance. What do we do with valacyclovir? Valacyclovir is definitely expensive, but better bioavailability and lower frequency of administration. And optimal recurrence-free interval before transplantation is minimum 6 months. It's better if we can follow for 1 year unless it's a one-night patient. And duration, it is an indefinite for long-term patient with multiple recurrence. What about the role of topical cyclosporin A or tacrolimus? So from take home message from this presentation is thorough preoperative assessment like sensation, preoperative vascularization, and meticulous postoperative surveillance should be tailored for each patient. And continue prophylactic oral acyclovir at least for 1 year to prevent the recurrence and distinguish graft rejection from viral recurrence after PK due to overlapping symptoms. So this flow chart says about, this is the latest survey ophthalmology was Manisha also represented. So if the patient is currently on antiviral prophylaxis, you adjust and go for keratoplasty. If the patient is not on antiviral, then you start, wait for some time, then go ahead. Even the cataract surgery, you also maintain antiviral prophylaxis for 1 month post-operatively. Thank you.
Thank you, ma'am, for that review and the treatment for the recurrence, which is very important in herpes. Next, we have our chief instructor, Dr. Praful Maharana. He will be talking about endothelial keratoplasty and viral endothelitis.
जल्दी आओ, slow motion में आ रहा. You can take few questions.
Any questions for ma'am about recurrence treatment? So, ma'am, I have one question. You said in your talk that tacrolimus or the cyclosporin can be tried. So, can they tried not for the graft per se, but can they be tried without steroid cover, just tacrolimus?
Yeah, especially if somebody is a steroid responder, for long term we can use tacrolimus. Hopefully tacrolimus will decrease the recurrence rate for.
Because there is another thought process where a few people say that along with the tacrolimus, you may reduce the local immunity to that level that it may increase the recurrence of virus to a certain extent. So even that thought process goes on. So the few people they stop the tacrolimus if the patient is on like.
I've not noticed the chances of high. Others can say if you use tacrolimus, is it more risk of recurrence compared to steroid? I'll see it will be less.
Or anything, you have to combine it with oral antivirals. So the dictum which we normally follow is whatever, like if you're giving twice, you have to give twice. And if you're giving more than 3 times, I mean that used to be more for prednisolone, then at least three tab ACU 3 times. So it's usually combined with oral. Giving only a topical, if you're giving it steroid or anything, especially post-keratoplasty, chances of recurrence is very high. Oral prophylaxis is a must. If the patient can't afford or is not, if it has a kidney problem or something, I mean, it's not approved, but we all have tried even topical acyclovir as a prophylaxis for a long time. I think we all have done it sometimes in desperate situations when it's a one-night and we do not want it to have another recurrence. Because
Thank
the more
you.
they have the recurrence, the more.
I'll start because the next session people are here. So my part is not that much. Whatever Sujata ma'am has discussed, that is very important. Because usually viral keratitis patient, they present with stromal scar. And most commonly either you go for DLK or PKP. But there are few rare instances where you can get endothelitis related endothelial decompensation. And at the start of the session, as I was telling you, over last 1 year, we have encountered 6 cases, such cases of endothelial failure, where the diagnosis was confused with PSCG or recurrent uveitis. Why? Because if you see this picture, so the pupil is mid-dilated, there are few patches of iris atrophy, and AC was also a little bit on shallow side. So that was the point of confusion. However, if you examine such cases carefully, you can see edema is there, you can see the classic patchy atrophy that is seen in recurrent HSV keratitis, and if you see here there are synechia with the lens capsule. So all these points, and if edema is not that severe, you can see the classical endothelial lines that is that was described by Dr. Sumit. So if you focus, pay attention, most of the cases you can see here there are multiple linear endothelitis lines here because of the recurrent attacks. So you can easily diagnose such cases. So how to manage such cases when there is corneal edema is there, but your superficial stroma is clear? So either you go for DMEC or you go for DSEC. DMEC, in contrast to other etiology, this is quite a useful technique compared to DSEC. I am a fan of DSEC, but this is one particular situation where I would go for DMEC rather than DSEC. Why? Because you have a lens, most of the patients are young, and unrolling the DMEC roll is quite easy in such patients. So, but one thing you have to remember, as what I did, pilocarpine is a must in all such patients. You can do a routine DMEC procedure like making 2-3 side ports, staining the endothelial layer, and one important thing, you can score the Desmet using air also, but for such cases where the lens is there, it has to be under Hilon cover. You should never try under air scoring. So DM scoring is easy in some cases, but there are cases where there will be dense fibrotic scar where it is often difficult. So it's always a good habit to place the DM roll that you have removed and to check that it is absolutely circular. So there are different techniques of graft insertion. What I prefer is using a Alcon D cartridge. It's quite easy, and the best part is you can inject the graft through 2.2 incision only, and you just need to connect it with a IB tube and with a 5 ml syringe behind that. You can pull the graft and then inject into the antechamber. So, and it's just a 2.2 incision, maximum you need to put one suture only. And since these are phakic patient, most of the time unrolling the graft, as I said at the onset, is quite easy. It doesn't cause that much problem. One precaution that you should always remember is don't try to collapse the antechamber completely, because with each attempt to collapse the antechamber, the lens keeps on moving forward and you may damage the interlens capsule. So this is it. This is a patient. This is the 2-year follow-up, and if you have heard me before this talk, this patient never allowed me to remove the suture because he has learned from Google that any trauma to cornea can incite a recurrency. So he never lets me remove the suture even if I counsel him a lot. So second important group of presentation is when the edema is little bit severe, as you can see here. And most of these patients, there is you will find the strange kind of epithelial hypertrophy is there, which is not like what we get in pseudophakic bullous keratopathy cases. Here, as you can see, this was the intra-op OCT picture. The steps are same, but here I would go for a DSEC because my visibility was little poor and the patient had some cataract. So I had in my mind, if required, I can go for a triple procedure. So I planned a DSEC, and doing DSEC is not a challenge in such patients. But compared to DMEC, you have to remember one thing, the operating space is very limited. In DSEC, you are transplanting Desmet endothelial roll plus 100 micron of stroma. So that further reduces that operating space. So you have to be utmost careful when you are managing your graft. I prefer a Bucin glide for injecting the graft and a corneocerebral tunnel for doing the DSEC. And at times, although in recorded videos it looks quite clear, but when you are sitting in the microscope, it causes a lot of scattering of light, this DM scar and the superficial scars. So at times is very difficult. You may hit the interlens capsule, so that you will have to be extra careful. So the golden rule is use pilocarpine and don't take any instrument through the pupil. Always try to bypass the pupil, and Third technique is, of course, at times you may get an older patient where you may have to go for a dissect triple procedure. Like this patient had a corneal edema. Now the challenge in this patients is not the performing the dissect, but doing a cataract surgery, because the scarring is deeper, and that is going to do a lot of problem when you are doing some critical steps like rhexis or emulsification. So all cases you have to stain the capsule. Viscoelastic you can use, that will give a temporary improvement to your visibility. Whenever you are doing rhexis, use a rhexis forceps and start your rhexis from some area which is clear, and then try to complete it in one go. Don't leave the flap when you are going through the scarred area. This is emulsification of the nucleus, and here remember one technique we defined it as phaco in situ. In situ means the moment you are dividing a pie or a piece, take it out, emulsify it out, then rotate the nucleus and then divide it again, then emulsify the small piece, then again keep on. So the point is keep on bringing your nucleus to here, divide it and simultaneously emulsify it. Once the phaco surgery is done, rest of the steps of dissects are similar to what I just discussed. But here, if you are doing a triple procedure, as I said, the space, the operating space is better compared to a phakic dissect. So you can be more comfortable while doing dissect in such patients. So the few things you should remember when you are doing endothelial keratoplasty in herpetic cases. Remember, there is a study where they found that if you do endothelial keratoplasty, the chances of progression of cataract, if the patient is young, mid 30s and 40s, increases by almost 7%. So if you are into a private practice, you should counsel the patient, even if I am doing endothelial keratoplasty, it may happen that I may have to do a cataract surgery very soon. Second, intraoperatively, as I highlighted it during all the videos, avoid lens trauma and stay out of the pupillary area. Use a peripheral iridectomy as good as you can. And post-operatively, as all the speakers highlighted, steroid is definitely you have to give, but oral acyclovir prophylaxis is very important. Steroid can give you symptomatic relief, but to decrease the viral load, you need oral acyclovir prophylaxis. The post-operatively, one surprising thing that I have noticed till now, out of the 6 cases we have operated, we haven't encountered any recurrence. It may recur subsequently, but till now we didn't have any recurrency. One thing that when I reviewed a lot of literature, one hypothesis, as ma'am was telling us, that there may be the viral latency may be other than neuron, they may be somewhere else. So there is a study where Aldaba et al. They did a biopsy of all the patients of PKP patients undergoing due to viral keratitis, and what they found that some virus particle were there in endothelium also. That could be one reason, because the virus latency may be in endothelium in such cases. Once you take out the endothelium, there may not be any recurrence or lower recurrence, because the virus still may be there in the neurons. With this, I'll conclude here, and I would like to invite you all to our annual DOS, which we are going to do at Bharat Mandapam from 13 to 15 June, New Delhi only. And thank you so much. Oral acyclovir 1 year is must in all our patients. After that, as Dr. Panisa highlighted, all these criteria, guidelines, they are in Western population. We don't know how our Indian people are going to react. So you will have to titrate depending on the frequency, severity, all this thing. Now I would like to invite Dr. John Sarkar, an excellent cornea surgeon, and also have a very keen interest in viral keratitis. And I have given him a very difficult topic. What are the recent advances in viral endothelitis? Dr. John, stage is yours.
Thank you, Dr. Prafulla, for giving me the opportunity, and thanks AIOS2025 for giving me this platform. So, very good afternoon to all of you. So, I'll be presenting the viral endothelitis, the future. I have no financial interest. So, I'm just sharing some, before my own talk, sharing few cases. 65-year male came with us for pain, photophobia with blurring of the vision right eye for 2 months with history recurrence of that time previously, with other is absolutely normal. And he sent to us for and diagnosed elsewhere as a phakic bullous keratopathy, and he was referred for endothelial keratoplasty. He was came like this feature, the area of stromal edema with the intact epithelium. There is no, and KPs are there, and the FS fluorescence staining negative. And age-old procedure we have done before staining, the kernel sensation reduced. And we do the ASOCT, and you can see there's plaque-like things there and the coarse endothelium. So probably I'm dealing with the case of the HSB. What we have done, give the topical steroid prednisolone given in one person in taperin dose, along with the therapeutic dose of acyclovir, 400 mg 5 times 2 weeks, followed by the therapeutic dose 400 mg BD for maintenance dose. So, and the result is that after a couple of weeks that comes with that is, so no need for the endothelial keratoplasty for this patient. So it sometimes mimic that you are dealing with, sometimes you may refer to these things that you are probably dealing with the ABK or PBK. You have to take the history properly and clinical examination properly. Case 2 is that 47-year male with the history of female with the history of diabetes, pain and redness for 2 months, and same I had some distant episode of redness long back, and she had for last 2 months the cocktail therapy with the moxifloxacin, natamycin, acyclovir eye ointment, and referred to us for the therapeutic PK. She came with these clinical features. Eyes very much congested, the hypopenia was there, the stromal necrosis was there, and we have done the scraping almost last 2 months. She was getting the moxifloxacin, natamycin, and acyclovir, all comes negative. So what we have done with routinely with the scraping, and plenty of pustules are there, no bacteria, no fungus, and probably I'm dealing with the HSB1. We have started the therapeutic dose of the acyclovir along with that as the eye was very much inflamed, and when the KVH was negative, oral acyclovir reduced the subset inflammation. Once the epithelium healed up, I started the topical prednisolone and tapered the rapid tapering of the oral steroids. And the result these things we have done the your acid tap for the HSB, and it comes positive. So these are some of the scenario. What we'll do for so the HSB keratitis remain the diagnostic and therapeutic challenges to the ophthalmologist, and it comes the diagnostic dilemma, recurrence, and the treatment strategies. And it has been very clearly that Manisha ma'am has explained these things. So they have the recurrence, why this recurrence and why this is explained very clearly explained to ma'am. So it's a HSB keratitis remain the leading infectious cause of the blindness worldwide, and approximately 1 to 1.5 million people, and 9 recurrence is there, and causing 40,000 new cases every year. So highlight of the presentation, what's new in etiological aspects, what new in the diagnostic aspects, and what new in the treatment aspects. So this study and published in this elsewhere, and is a eye opener of this why exactly what happened, and these things explain this thing. All of us know that it has been almost century back with those explain this thing. There's existence of the endothelitis which has been well treated by the topical steroid. Subsequently accumulating the evidence has been shown that the disease etiology consists of various viral infection including the HSV, varicella zoster virus, mumps virus, and the cytomegalovirus. Sometimes we have found the Coxsackie and adenovirus too also, and Epstein virus. The pathogenesis of the corneal endothelitis is not fully understood when the role of toll-like receptor TLR and the pattern recognition receptor that initiate the innate immune response, and that is the most we have to hit that area, and the molecular level where I tried, madam was trying to be inference these things. Now we grossly were even the acyclovir topical steroid, but we have to be advanced in thinking for the at the molecular level. So this flowchart, I love this flowchart because the toll-like receptor pattern recognition receptors that initiate the immune response to the endothelial level, and why there is a recurrence is there, why the stopping these sometimes the cells embedded with the your virus load. So that why the where it is embedded the toll-like receptor 9 which recognize the bacterial or viral DNA and RNA containing the unmethylated sin, and that is immune reaction is there. I'm not going in details for the passage of time. That the upregulation of the pro-inflammatory cytokines and the chemokines in the corneal endothelial level interact with the HSV1 and could be reduced by treatment of the your which is toll-like receptor 9 inhibitory oligonucleotides. So their results suggest that the toll-like receptor 9 signaling the may play a major role in inflamed viral corneal endothelitis. So that's why with steroid is subsiding, but we have to be give the oral acyclovir or therapeutic doses. Along with that, we have to be things for the molecular level in advance of management. But so now clinical categories already that Sumit is very nicely explained. I'm going not in details. Mainly the disciform, diffuse and linear one. This is the clinical diagnosis. These are maybe the some things I'm skipping this size because already he has explained this thing very nicely on the first talk. So these are some of the patients who came with the your HSB recurrence in the graft one. That is really confusing whether it is HSB recurrence or is a graft rejection. So differentiating point is that, so the madam was initially asking. So if it is a HSB endothelitis, you will give the fold in the DMs and the records KPs are there, and had a definite history of the recurrence is there, and shoot up IOP is one of the most prominent factor. So how to diagnose the HSB endothelitis? So diagnostic test is maybe the laboratory test, the viral culture, polymerase chain reaction, immunofluorescence assay, and the GM staining. Or imaging technique, it may be the antrosegment AIOS2025 in vivo confocal microscopy, or what the newer diagnostic then in the multiplex dose hybridization MDH assay or immunohistochemical assay or ICGA. So PCR is definitely the HSV DNA. The rapid one, the sensitivity is approximately 70%, and the type of it may be conventional PCR, the real-time PCR, or the multiplex PCR. What exactly PCR is doing? They much more specialize the things clinically assist your diagnostics. Whenever you are confusing whether I should give therapeutic one or not, specifically the first cases where I discussed, there is a send you as a PBK or ABK. Then if you have a doubt of these things, it will give the very clear cut thing. If you do simple PCR in OPD process to also send for the your even also pen your PCR all the multivirus, I mean CMV virus, HSB1, HSB2, and if it's a single genome is there, it will multiply the thing and give you the result. So it will give you assist to the diagnosis and the treatment part too also. And I'm going and and it's very specific. The specificity is that 71.4%. And it also gives the quantitative assay for the real-time PCR, how much the virus load is there. So you can indirectly top up your dose of the oral acyclovir and accordingly, or the therapeutic one, how long you will produce. Another assisting diagnostic is that your confocal in vivo confocal microscopy. What exactly you will get in the confocal microscopy? You will see the gutata enlargement on intercellular gap, and there is infiltration of the inflammatory cells in between the endothelial cells, and the loss of cell and defined the cell boundaries and endothelial denaturation. But the thing is that these are the showing this thing, this virally laden cell, and when you give the treatment with topical steroid along with the oral acyclovir, it comes normal. No signs of endothelitis 3 weeks after initial approach, appropriate antiviral therapy, and it has comes to become looks like a normal. But the limitation is that the viral particles which is there, they can't be limited. The limitation is there whether it is active or not or something. They can't be to confocal microscopy to can't put, the pick up the things. So these are the another diagnostic modalities that the Shumit has explained the thing. Due to paucity of time, I am just escaping. That can be things to rule out. And keratic precipitate, we'll see. This is the pre-treatment and the post-treatment, how it looks like the endothelium. And so whenever you are dealing with these things and you try to diagnose by the ASOCT, but always keep in mind on a loop that you should be rule out the phakic or pseudophakic corneal edema, Fuchs endothelial dystrophy, primary ankylosing glaucomas, or other HSV endothelitis like CMV, HZV, and the Fuchs heterochromatic iridocyclitis and Boxner-Stockner syndrome and eye syndrome. But now the treatment part. What's new in the treatment? As all of us know, this thing already previous speaker explained the thing. The prednisolone acetate or the dexamethasone 0.1% has to be given. You have to pick a topical steroid along with that oral as a main mode of treatment. Whatever you are giving, the therapeutic dose is standard therapeutic dose 400 milligram 5 times 2 weeks, followed by 400 milligram BD for minimum 3 months or more than that, even sometimes 6 months or a year, depending on the clinical scenario and how the patient responds. And tapering of the steroid, what the madam was initially asking, and the Dr. Madam Manisha Ma was trying to be clarify these things. Even sometimes, what usually my patient, I usually taper very slowly after when it is not like the cataract prednisolone, the 64321, even one alternate day, 2 alternate day, sometime and gradually like that, and with monitoring of the IOP, and most of the time HSV endothelial associated trabeculitis, we have to address the intraocular pressure. So even with this, now what's new with that? Now surgical aspect, I'm not going in details. This patient came to us for this PBK. We have done the ultrasound dissect for this patient. Is a one-eyed patient, and I'm just skipping the video that because Dr. Praful was in the very nice video. The outcome of this patient is ultrasound dissect is that the one-eyed patient. You can see the visual acuity 6/12 is unaided, and the other eye no pale. And this is the your specular microscope postoperatively and the ASOCT. So what is the immunomodulator? Now the role of the tissue immunomodulator specific treatment for the addressing the CD4 your receptor cells and the molecular level. In human recurrence herpes infection, both the CD4 and the TRM persisting between the lesion may control the asymptomatic shedding of through the interferon gamma section. Although this has been more clearly shown, the CD4 cells are more responsible for that.
John, can you please conclude in
Yes,
1 minute?
ma'am. I am just concluding. There's role of the inflamed role of CXL is there, and role of vaccination. Yeah, combination of the herpes simplex vaccination strategies from the besides the two bench and back. That's mean whenever we have the things we are thinking of the vaccination, vaccine very this mean priming and pool vaccination approach. That's mean first priming the antiviral effector memory T cell and systematically then pulling them to the virus replication site, the sensory ganglion and the replication site, the eyes or the vaginal mucosa, and that can have probably hit the suppression of the patient and the reduce the virus load, even also asymptomatic the HSV positive patient too also. And the PRK vaccine, how they work, this is the schematic presentation. So what to do the neovasculation that has been covered by the ma'am too also. So always HSV infection there is a tendency for the neovasculation, we have to be address these things. We can give the anti-VEGF or the topical your steroid very low dose, even sometimes we give in the Kenacort injection to the steroid before the transplantation to improve the graft survival rates. So point to be pondered, the HSV endothelitis characterizes a potentially blinding disease. Accurate and prompt diagnosis and the treatment with the steroid is necessary to prevent the long-term sequelae. Differential diagnosis of HSV endothelitis needs to be considered in atypical cases. Clinical diagnosis usually work well. However, microbiology and other laboratory tests, likely quantitative PCR of the aqueous humor, is informative for doubtful cases. And do we need to further research for prove the beneficial effect of the newer medicine? Yes, that's why Manisha madam is telling we have to be addressed by molecule think for the molecular level. And I hope that it will become soon, down the decades or years. Can we prevent the recurrence by eliminating the virus in the latent stage in the trigeminal ganglion by immunology or molecular biology? Yes, or by vaccination, by priming and pool vaccination methods. And can vaccination be used to increase the protection from the ocular herpes viral infection? Yes, that can be done. And these are the patient of the different panorama of the HSV, and these are all the smiling face of the eyes. Thank you very much.
Thank you,
patience sharing.
Dr. Jovan. We finally concluded in time.
Thank you
And
very
thank you
much.
all of you for this attending this IC. We'll have a photograph downstairs only. Meanwhile, I would like to invite Dr. Srinivas, and lot of students are waiting here for the competition Student of the Year. All the best to all the students.
Thank you, Dr. Prafulla Marana and the entire team, Sumit, for handing us over the session on time. Thank you.